Welcome to this presentation on measuring deprivation in Humber Coast and Vale Integrated Care System. I'm going to talk about some principles, some pitfalls and some opportunities. Health inequalities within our decision making are really important within Humber Coast and Vale. We're tasked with arranging and planning healthcare for 1.7 million people, and we know that healthcare services can reduce health inequalities if they're delivered in the right way, but they can also serve to exacerbate them, and they frequently do. We're trying to avoid what Julian Tudor Hart called the inverse care law. The more any community needs good medical care, the less likely it is to receive this. This is one of our 4 missions within the integrated care system. We're trying to tackle inequalities in the way we deliver healthcare. And the most consistent determinant of health inequalities in the UK is your postcode. That's why within the ICS's mission to reduce inequalities, we're using the national framework of Core 20 plus 5. We can talk about the plus 5 in other fora, but the Core 20 aspect of this talks about the most deprived 20% of the national population identified by the Index of Multiple Deprivation. But what is deprivation? Who are the bottom 20% in Humber Coast and Vale? How do we identify them correctly? And how do we use the concept of deprivation carefully within healthcare decision making? So let's introduce the Index of Multiple Deprivation. The indices of deprivation provide a relative measure of deprivation for small areas. These are neighbourhoods of about 1,000 to 1,500 people. England is divided into around 32,000 of them, and each one are given a score and a rank on domains of deprivation within the indices of deprivation. A higher score is a greater level of deprivation, and a rank of 1 indicates the most deprived area. And the index is made of 7 different domains, and each domain itself is made up of subdomains. So, for instance, the living environment domain has within it housing in poor condition, houses without central heating, air quality, road traffic. The crime domain is made up of violence, burglary, theft and criminal damage, and there are some whizzy maths to put these things together and come up with overall scores. The domains can then be combined to give the index of multiple deprivation for each small area, and areas can be ranked and scored to compare. This means, however, that the overall IMD rank or score on an area is a composite of 7 domains, which each have 4 to 6 indicators. So the IMD is a summary indicator of a number of summary indicators, and details can be lost in the process. So some key things to note. The index measures deprivation on a relative rather than absolute scale. So an area that's ranked 100th is more deprived than one that's ranked 200th, but it doesn't mean it's twice as deprived. The level of deprivation in an area doesn't apply to every person that lives in that small area. That's what epidemiologists call the ecological fallacy. The IMD is good at measuring the presence or the absence of deprivation, but it's not as good at measuring affluence. It's not particularly good at comparing trends over time because of the way the different areas shift in relation to one another. Differences between the least deprived areas are less well defined than differences between more deprived areas. And we have to be careful because the IMD is a deficit-based model of understanding population health. It doesn't take into account the presence or the absence of health assets within a community. So thinking about what we might see sometimes, an overall IMD score or a rank for an area, what does it mean? Well, it comes in different flavours, and I won't go through them in detail, but we could talk about average ranks, average scores, we could talk about a concentration summary, we could talk about the proportion of LSOAs in the most deprived 10% nationally. So there are different ways that the index is summarised. A key policy paper recommends that the IMD rank and deciles are used rather than the score. However, scores might be helpful if you're interested in correlation between variables because they're a particular type of variable, continuous, not a categorical variable. And we have to be careful with general practice IMD data. It's presented by the average IMD score of all LSOAs, all small areas where the practice is the most likely primary practice. But this covers often a lot of quite dispersed lower super output areas that don't really fit into common geographies like wards or even local authorities. So does this tell us what we think it's telling us? Let's think about an active example. Let's think about two different areas and how using IMD might lead us to certain conclusions. Area 1 has lots of quite stark poverty and people living in the very sort of lowest centile, the lowest percentage of the population, and 5% perhaps in area 1 in that grouping, but then a ring of suburbia around about midway in the deprivation index, and that may be accounting for about 45% of the population, and that being surrounded by affluent countryside, maybe some market towns, maybe the 50% of the population living in that surrounding area. Here we would conclude that the area has high local concentration. So in that sense, it's very deprived. It has low bottom 10% proportion or extent. So we might actually say it doesn't seem very deprived, and it has a medium to low average rank or score. Compare that to area 2, which has large clusters of rural poverty around the second and third decile, so not absolute poverty, but just above, and maybe 40% of the population in that category, or 45%. Doesn't have many LSOAs in the bottom 10%, and it does have, again, that surrounding affluent countryside. We'd have to conclude that this has low local concentration, has low bottom 10% proportion, it's medium when it comes to the most deprived extent, and it's medium to high when it comes to average rank, so not particularly deprived. These are two areas that are made up but are quite similar to areas that we often find in local authorities, and we would come to conclusions on them, not necessarily the right ones if we don't choose the right type of IMD measure to use. Thinking about the deprivation deciles in Humber, Coast and Vale. Here we have a map. Its middle super output area is slightly larger here, and showing that we have areas that are towards the red end, more deprived in various bits of our geography, particularly around the east coast and around the city of Hull and northeast links local authority area. Some observations on this. We know that the bottom 10% often have the worst health outcomes. That's the well-known cliff edge effect. And actually the number of areas in Humber, Coast and Vale which are in this category or have somewhere a small area in this category, it's probably larger than we think. So York, Scarborough, Selby, Bridlington, Harrogate, Hull, Scunthorpe, Grimsby and Withensea all have a bottom 10% area. But there are some clear clusters that we're probably aware of. Again, that East Coast deprivation effect is very clear. Our average IMD score is slightly lower than the English average. However, the percentage of our areas that are in the bottom 10% is slightly higher. So there are different ways we measure deprivation. We get slightly different results for the whole of Humber, Coast and Vale. And there are 143 small areas in the bottom 10% in Humber, Coast and Vale. So you remember these are between 1,000 and 1,500 population. So quite a significant number of people clustered in Hull, in northeast links and in some other areas, but they are present, as I said, in most of these areas. Let's think about this visually. What you have here on the slide is a grid made up of around 32,000 blocks. There are 32,000 lower super output areas, small areas within the index of multiple deprivation. And if we just think about the two at the ends of the extreme within Humber, Coast and Vale, Humber, Coast and Vale has the second least deprived small area out of the 32,000. That's in Harrogate 021A. And it also has the 21st most deprived small area out of 32,000. That's in Hull 017E. So probably some of the starkest health inequalities and social inequalities that you'll find in any integrated care system in the country. We could also look at this data from a different lens and think about what proportion of our small areas in each decile. The England bar chart on the right shows that an even proportion, 10% are in each decile, as you might expect. And of course, in Humber, Coast and Vale, it's slightly different. So if we're thinking about the lowest decile, as I've noted, we've got a higher number, higher than 10% of our population are in that decile. But if we're thinking about the bottom 20%, actually it's lower. It's 18.7%, not 20%. And again, the bottom half that's lower too. That's around about 41.6% rather than 50%, which is the national. We could think about one particular domain, just to turn it around a bit from some of the other indices that we've looked at, and think about barriers to housing and services. There's clearly more deprivation on this score related to rurality than other elements of IMD. North Yorkshire and East Riding are therefore significantly more disadvantaged than Hull or York or Humber. There's some surprising areas of problematic access to the services: south of Pocklington, South Selby, northwest of York, west of Harrogate. There are 4 North Yorkshire districts with particularly poor access to the service: Harrogate, Richmondshire, Hambleton and Rydale. And interestingly, one of the most deprived middle super output areas in Humber Coast and Vale, which is in North East Links, it's the most deprived on the composite average score, but on this particular domain, it's in the 9th decile, so the second to least deprived decile. So again, you can't make simplistic judgments. We could also think about the different domains and of the domains, which of our small areas are in the bottom 10%. And as you can see, it ranges, but in the health, deprivation and disability domain, we have 15% of our small areas in that bottom 10%. So potentially our health problems are driving some other elements of deprivation. A lot of this data is much better understood if you play around with it yourself. So just invite you to register with the Shape Atlas, which will help you explore the 7 domains of IMD for Humber Coast and Vale. So some conclusions and some observations. First of all, if you're using index of multiple deprivation, use the smallest and most geographically homogeneous area possible. That's the way you're most likely to generate the most valid conclusions. When you're making decisions using deprivation scores, try to avoid a number of missteps. Try to avoid the ecological fallacy, where we assume that data on a geographical area is going to apply to everyone living in the area. Try to avoid the masking fallacy. In larger geographies, inequality and deprivation is often masked by averaging. And try to avoid a domain fallacy, where low levels of deprivation in overall IMD score high deprivation in one of the domains. So if you're planning services and access to services, you don't want to think about the overall score, you want to think about the domain around barriers to access and housing. General practice IMD scores really should be used with caution. GP geographies are often not best suited to using an aggregate score. Overall, we can conclude that Humber Coast and Vale has more extreme deprivation, the bottom 10 and 1%, but fewer people living in the bottom half of deprivation. So we're more polarised than the national average. The deprivation domain with the highest proportion is, as noted, the health, deprivation and disability domain. So we may be seeing there that health outcomes are a larger contributor to overall level of deprivation than in other integrated care systems. And finally, evidence shows that the bottom 10% most deprived communities and within the bottom 1% most marginalised groups, often from an inclusion health perspective, they suffer the disproportionate health inequalities, the cliff edges, which we've noted. So even though we have a national mandate around core 20 plus 5, the bottom 20% on the IMD score is not necessarily the best grouping for tackling health inequalities, and you might want to think about using the bottom 10% or even the bottom 1%. Thank you for watching this presentation, and I welcome any questions to the email address on the slide.